Okay, good morning, everybody. We're going to go ahead and get started. This session is being recorded. In case you get kicked out, you want to return to it, there will be a recording. I've also put in the chat the link to the conference website. In case you do get kicked out for any reason, you can go back to the conference website. That's where you'll find the plenary session, a link for that, and links for all of the sessions. So my name is Zoe Lewis. I am the SSVF and HVRP Program Director at Catholic Charities Hawaii, two veterans programs. And I'm really pleased to introduce for you today Mary Harlinger. She is, hold on, let me pull up your bio, Mary. Mary is a clinical psychologist with the VA Pacific Islands Healthcare System. She also serves as the LGBT Veteran Care Coordinator, and she works as part of the Health Promotion and Disease Prevention team. So Mary's going to share with us a presentation on working with women and gender diverse veterans. So we're really excited. All right, Mary, I'll hand it over to you.
Great. Pronouns are she and her. And as Zoe said, I'm with the VA Pacific Islands. And what I'd like to talk about a little bit today is some background information about working with these two special populations, and then generate some ideas or thoughts that we might consider when we're working with these populations.
Sorry, Mary, one thing I did forget to announce to everybody, if you guys have questions, if you could please add them in the chat or in the Q&A, we'll get to questions at the end. Okay, thanks. Thank you, Mary.
Wonderful, thanks. So when we start to think about these two special populations, sometimes the question of why would we consider gender or gender identity when we're trying to address housing needs? And I think this is an important question because I think it's a question that veterans also have, and it's important for us to really think about the way we view healthcare, the way we view housing, and the way we view special needs in the context of doing our best to model the integration of multiple variables and how they really overlap and really affect each other in a pretty significant way. And so typically in live presentations, I'd kind of ask for people to generate some ideas of why they might think these might overlap. But since we're in a new format, I'll ask everyone to kind of think about that themselves and see if they can think of a reason. What might be, a reason? For me, what I think about is the fact that, recent publication from the Housing and Urban Development saying that they were going to change the ruling on who can access single-sex housing facilities. So the idea that the people working in these facilities would be looking at exterior features as ways to decide if someone was allowed to come in. And so the proposed guidance included things like looking for an Adam's apple when someone came to, a female designated shelter. And so when we think about gender and gender identity, this can be absolutely on an individual level, but it goes all the way up to system, organizational, policies. And so when we start to consider these, we can see that it's important for us to realize how it interfaces with each other so that we can make informed decisions and provide the individuals we're working with good information. So backing it up, when we think about how this all plays in together, the idea of social determinants of health. And some people might be really familiar with this, but if you've never heard of this before, it's the idea that when we really start to expand our understanding of healthcare, our understanding of what health really encompasses, it's much more than we often consider. And so in this little graphic here, you can see there are a lot of things that we don't always necessarily instinctively, or maybe I didn't at least, and I assume there's probably others too, that don't always think about how this directly affects healthcare. Things that are a little bit more commonly connected to healthcare might be like mental health, right? Or just general access to care, being able to get to that care. But we also want to think about, during COVID-19, isolation. That's a part of one's health. The ability to have access to food. So we think about, food deserts or um, transportation, being able to actually get to care, especially when we think about the Pacific Islands and the different areas that we might serve. It's not so simple as, okay, here's a travel voucher. It requires a lot of steps along the way. So housing is absolutely part of this. And so what this means is each of these, when we start to look at an individual in context to these different factors, we can get a much deeper understanding of what their needs might be and how to better address their health. So as a clinical psychologist, what I'm really wanting to think about and what I would like to focus on is the idea that we know that healthcare inequities exist. And so how do we best provide avenues, education, or outreach to do the best that we can to start to reduce those inequities? Simply kind of saying that the same care is available for everyone doesn't necessarily reduce inequities because it doesn't address these contextual factors that it may be, someone might be dealing with hunger. That's going to affect their ability to focus and attend to other needs. Someone might have more or less education or just information about how to access healthcare. So we want to think about those things in particular. Excuse me. So as I noted, healthcare disparities or inequities, it's basically the idea that we can see a clear difference in health status between different groups of people. And so this can be from intentional harm, right? It might be something that's intentionally decided upon, but it can also be unintentional. So this idea that if we're not aware of the needs of the people that we serve, we might unintentionally perpetuate or add to a healthcare disparity. So we really just want to be thoughtful about, even if we're not intentionally doing something, if we're not always kind of arming ourselves with good information and knowledge, we might unintentionally add to this dynamic. So when we start to kind of attend to this two groups that I want to talk to y'all about today, it's really important for us to throw in there Myers Minority Stress Model. So this is a model or a framework that when someone is in a minority group of some sort, there are societal structures that create a chronic stress. So we think about the fact that right now, COVID, that is a huge stressor on us all. But it may or may not have different types of effects on people depending on the other stressors in their life. If someone doesn't have reliable connection to internet, for instance, accessing virtual town halls, social groups, social outlets, maybe faith-based programs, things that might help them be more connected, would not be an avenue for them. So what this is simply saying is we want to consider that we have kind of general life stressors. We have unique stressors for each person. And then if a person belongs to a minority group, that adds even another layer of stress. And it's that societal structure stress. Okay, so it's just the idea that we want to, again, always be thinking of our individuals that we serve and ourselves, honestly, as really complex people that have a lot of different things that we're trying to get our needs met, I guess. So this is kind of a complicated infographic, but that's kind of a good thing because this really emphasizes that this is what our experience is like. So it's not particularly important that you memorize or know all of these different factors, but it's the idea of really emphasizing that within a system, there are many variables. And they're kind of pointing all over the place and they're circling around. There's so much going on. That's someone's lived experience. So as I noted, they might be going through general stress. There might be some external minority stress, maybe related to, oh, there's a new policy about, a shelter that I've previously accessed. It might be that there's some mental health concerns. individuals might have individual resources, like someone might have family support, someone might not have any family support. So this is really just about thinking about that it's not kind of a, point A to point B. There are many things going on. So first, thinking about women veterans. They are a minority in our VA healthcare system. They're about 7% of our population. And typically they have much more complex needs. This can be related to that their general exposure to trauma and stress in the military is higher than men. Things like military sexual trauma, trying to balance caregiving needs. There's different factors that might influence them. But the thing that's really important for us to realize is that women veterans typically have to have multiple visits. They have to keep going back. They have to keep asking for additional services, and they continually refer to additional providers to get the same level of care that men are able to get in one single visit. So you think about kind of the exhausting nature of that, right? Government agencies are already pretty complex and tricky to navigate. And then we're saying, okay, simply the nature of your needs require you to work even harder to get the same level of care. Across the VA, maternity care is traditionally not offered at the VA. It's something that not just here in the Pacific Islands, but across the board, virtually almost all VA medical centers contract that out to the community. So if you're trying to get multiple things met, you can't even go to the same facility. You have to access outside resources. It's another appointment. In general, women veterans are going to be more likely to be homeless than non-veteran women. So we see that this is actually a risk factor. If someone is a woman veteran, we know that they're at a greater risk to be homeless or unhoused. And so when we think about that, we want to make sure that we're really attending to this. This is a variable that can affect, the type of resources or the type of outreach that we attend to. Similarly, when we think about LGBT veterans, they're going to be at a greater risk for significant mental health factors. I put suicide. September is Suicide Prevention Month, and so we want to think about that. Something like transgender veterans, they are 20 times more at risk, higher risk than general veteran populations. And the veteran population is already at a higher risk for suicide than non-veteran populations. So this is a significant concern. If we look at specifically transgender adults, they're going to typically have, they're twice as likely to experience housing instability. So again, a lot of this is the background of us trying to make sure we're thoughtful that this isn't just another checkbox. This isn't something that we're asking in the same way that we need to know just general background. These are significant risk factors that will affect the likelihood of them needing resources and being able to get the resources they need. So just in case, I've said that I've kind of alluded to this, but just in sometimes people have more or less awareness. So LGBT, this presentation, I want us to be really thoughtful about gender expansive or transgender veterans, but oftentimes we think about them as a minority group. LGBT is kind of classified together. So we have lesbian, gay, bisexual, and then that transgender, gender diverse, 3 different categories. So the first 3 are looking at the sexual orientation, who someone is attracted to. And that last category, transgender, is thinking about the way someone is able to identify their gender that might vary, that might vary from socially defined norms, socially defined roles. So this is just the idea that because of that, oftentimes people may not be as familiar, and as a result, that minority stress might kind of be a layer to that. This idea that when we're not as aware, when it's something that we're less familiar with, we might be perpetuating harm without realizing it. So we have that sexual orientation, and we have that gender identity. So when I've talked about transgender veterans, just in case, kind of bring that information or review it for some. This is a great model if transgender or gender expansive identities are something that are unfamiliar to you. We have our little gender unicorn. And basically, this is just helping us remember when we're gathering these variables that it's kind of in different categories. They don't have to overlap. They might, but there's these different areas. So it might be someone's gender identity, might be different from their gender expression, which might be different from the sex that they were assigned at birth. These are all different variables. And so we just want to have a good awareness so that we're able to understand again what the needs might be. So thinking about how this affects the way we interact with the individuals that we're serving, we want to think about that veterans are going to be significantly impacted by the military culture that they were a part of. So military culture has a heavy emphasis on like the regulations around appearance. So what might happen is that someone's gender expression might cause them to worry about the way they're going to be treated. They might not ask for help. If we think about someone that has been unhoused for a significant period of time, right, it might be difficult to maintain hygiene, and that might be a barrier where they say, you know what, like I'm not following kind of this instilled regulation around my appearance. I'll wait until I'm able to kind of change my appearance a little bit, and then I'll reach out for help. There's lots of variables that could go into that, but we want to think about military culture puts a huge emphasis on appearance. And so what happens when their appearance maybe doesn't fall into those guidelines? We want to think about that military culture also puts a lot of emphasis on gender roles, and that there's different kind of rules about who can be in what kind of jobs, who can be deployed where, who can do what, and with whom. And so, again, thinking about a person's kind of feeling of being welcomed into an environment is certainly going to be affected by this. Part of that military culture is a strong emphasis on kind of following these rules, following these regulations. And so most veterans report, a pretty significant difficulty of letting the regulations, the rules go when they transition out of the military, simply because it was such a huge part of their life. So important for us to kind of think about that even if they're a veteran, even if they're not in the military, it's certainly like kind of that voice in their head that's saying, hey, this is what you're supposed to be doing. So they can often be, really affected by that. We think about the feelings of safety in military culture. As a simple example, military sexual trauma is pervasive for both men and women, transgender veterans across the board. And so oftentimes military culture can really be that physical safety might be a piece of it, but it also might be the idea that you're not going to be able to get promoted, move up in rank, kind of get the things that you need if you disclose your needs. So traditionally, mental health has, a very significant stigma in the military because it could affect your ability to move up. So what does that mean that when we interact and work with these individuals, they might, again, have that kind of voice that's like, I probably shouldn't tell you all of this. I probably shouldn't disclose all of these things. Okay? We have the don't ask, don't tell policy, and then the ban on transgender military service members. So again, we're talking about individuals that have significant lived experience, that being a woman, being a transgender veteran, falling into some sort of kind of minority group in the military means that they don't have access to that. And there's really not any avenue for them to resolve that. So it would make sense that they would carry those beliefs into their kind of civilian life after they've left the military. One good resource that I just encourage people to look at overall is the Veterans History Project. And my presentation has all of the different links to this information, so I'm happy to share that. But what this does is this interviews veterans and talks about their lived experience. And so there's one interview that I mean, they're all very powerful. One interview I found really powerful is this where this veteran's talking about, it was during Don't Ask, Don't Tell, a gay man, and talking about that one of his subordinates was reported as being a lesbian, and he didn't know what to do because not only did he kind of share the fear of being outed, but also the fact that they're asking for his feedback in how to discharge this veteran. And he doesn't know what to do because, like if he speaks truthfully about the matter, this is probably his best, employee, his best subordinate he has. But it didn't matter. It didn't matter if he supported her. It didn't matter what her work was, because if you disclosed, if you were found out, if you were outed, they didn't want you. And so when we think about that, what we really want to think about, again, is that when individuals are going to be coming up to these systems, up to us, any of these things, there's likely going to be a significant concern, right? Like there's going to be this idea that I don't know that I can trust you. I don't know that you really have my best interest at heart. And that makes sense. That suspicion is based in a lived reality. So I think that's important for us to really be thoughtful about. Because what's happening is they're coming into this with questions like, is this culture, is this agency, is this person sexist, transphobic? Am I going to be accepted, right? So maybe I worry about this, so I only give this amount of information. And so, we provide this resources that fit the information that we were given, but we haven't actually addressed what was needed. There's these really unique challenges, right? So when we think about people that fall into LGBT kind of status, they're constantly having to come out. It's not something that's apparent. So there's just this added pressure of should I not? Should I not? They're not sure, is this going to be a safe person? And then we consider it like in the healthcare realm, they don't know if their provider is going to have what they need. A lot of the research around women veterans in particular talk about because most VA providers serve majority men, they typically don't have the training and expertise, the ongoing, right? They might have that foundational base, but they're not attending ongoing, like continuing education. They're not seeking out information. They're not learning or tapping into resources within the VA that are specifically for women. So, even if I get a great provider, they might not even know what I need. And then there's the administrative side of it, right? So like just the idea of what I've mentioned before, the societal structures that exist. And so thinking like, okay, this might be something, that's helpful to me, but maybe not. They don't know. And so really going back to what I started is thinking that housing is a type of healthcare. We can see that when someone is unhoused, they're going to have a significant higher incident rates of really serious conditions, really chronic conditions. And so addressing housing as a healthcare issue, we're addressing these long-term conditions. And so that's important, I think, regardless if someone works in healthcare or not. We think about that really integrated approach of, okay, if we're trying to address someone's needs, we have to think about all of the things that they're experiencing. So what should we be considering? The first thing we want to think about is our own interaction with these individuals. We want to think about the fact that there might be emotional or moral injury that they've experienced, because that might interface with what's going on in the room. There might be this suspicion, there might be this concern. There's likely some really deeply held beliefs about the world, about themselves and their identity. As I mentioned before, military culture, it has a very strong influence on people for the rest of their lives. So whatever kind of belief system that they really built in the military, it's either going to be this experience of they continue to believe that, or it's, like they're lost. I thought I believed this, and now I'm kind of purposeless. I don't even know what to believe anymore. So you have to consider people in the room are going to be experiencing that. And so you as the support person, you as the resource, the ally, the friend, whatever it might be, we have to think about how's that interplaying with what's going on with me. The idea that there's going to be more triggering events. So we think about oftentimes there's going to be a higher likelihood for both women and transgender veterans to have more trauma events over their lifetime, which we also know to be true for unhoused or homeless populations, right? So trauma is really prevalent across the board. And so what does that mean? It might mean that, my stimulus value might mean that they come into the room, come into the office, and okay, I don't want anything to do with this person. This person represents something that was really painful for me. So we have to be thoughtful about that. And then we also want to just be thoughtful about our own personal assumptions, our own knowledge base. And I think that's kind of when we work in any type of serving field, we always want to be thoughtful about that. Like, how does my own experience, how does my own knowledge base affect how I'm interacting with somebody? So what we want to think about is kind of creating a culture of affirmation in the room. This is really tangible, like something that I can have power over this interaction. So what does it mean when I say personal stimulus value? What does it mean? Your own visible or maybe not visible, maybe things that they're making assumptions about due to this person. I'm white. So what might that do to someone? That personal stimulus value as they walk in and they see a white provider, that can create an interaction before any interaction has happened. So I just have to be thoughtful about that. I have to engage in what might that mean. It can be really important for us to normalize the impact of minority stress. And by this, what we should do, or what we can do, is provide information and education to veterans and individuals that that's what's happening. Sometimes providing clarity, information about an experience can be really empowering, because then it's not just in their head. It's not just another complaint, which often, especially with veterans, we can hear that military culture pop up. They shouldn't complain. They shouldn't have a problem. Others have it worse than me. I speak to so many veterans that really talk about how, it took me years to come to the VA because, there's so many veterans that I know that have it so much worse than me. And, and the veteran that's saying this, he or she has really needed, to use gender expansive terminology, they have really experienced so much, and they have needed and deserve health care too, but they prevented themselves from accessing that care. And so we want to normalize it and give that information to them. We want to try to teach assertive communication. And this can be, an ongoing lesson for ourselves as well. How do we help people find the words that really value their needs? As I mentioned before, government agencies, they are a tricky thing to navigate. And so how do we help people find the words so that they can say, I understand that you don't know about this service, but this service exists and I'm eligible and I need to, access it. And so thinking about that might be done through modeling, through care coordination, coaching, ongoing support. We really want to validate the unique strengths of women or LGBT transgender individuals without romanticizing their hardship. Something I always really encourage people to think about, especially with special populations, is we'll make an attempt that we're trying to validate, but instead what we really do is like, wow, you are so strong. You must have grown so much. And we really put their pain as kind of like the ticket to their worth and them being deserving of care or resources. And, I think I can say this with, pretty confident assurity. No one, believes that someone has to suffer, or I hope no one believes that someone has to suffer to be able to have access to resources. And so we really want to make sure we're not accidentally kind of implying that. Instead, we want to think about that strengths-based approach, that being a woman, being transgender, individual, falling into an LGBT category, there's a lot of resilience in these populations. And so how do we validate that, like, they have survived, they have been resilient, they have gotten through this? You know, they were able to maneuver military culture, which has so many different, barriers. They can navigate these situations too, and how can we support that? And then, of course, fostering and encouraging supportive relationships, connecting with their community, whatever that might look like, whether that's with support groups, friendships, or actually community organizations. We really want to try to be authentic in our language, in the way we present. Sometimes when we're really trying to be thoughtful, we might come off as condescending. And so trying to speak in an authentic way. And it might be, I've worked with some providers that say, I'm not very familiar working with a transgender veteran, so I'm not really sure what to say, so I don't want to say anything at all. Well, that might be like an unintentional harm. And so what I encourage people to do is to be really authentic. I want to help you, and I've realized that there's some areas that I don't know, so I've reached out for help. However, I realize that, I'm still learning, and so I'm going to be open to feedback. I'm going to try to make sure that I'm thoughtful about, inclusivity. And that would be perfectly fine. And most providers find that when they do have that kind of authentic, compassionate conversation, that people are really open to it because they feel welcomed, even if they might not have all of the knowledge that they need right from the start. So finding that language of acceptance, right? Oftentimes it's kind of implied, something like introducing yourself with your pronouns, putting it on your presentations. Earlier, I was speaking about veterans and I said he or she, but that's not inclusive, right? We're not didn't include gender expansive veterans, and that's an entire population. And so kind of saying, oops, like I made a mistake, and like being very thoughtful about that doesn't mean, that, oh, you're so bad, and turning it into, oh, this guilt. Let's shift the whole conversation where now the veteran or the individual can't get their needs met. Let me correct my mistake and then move forward, because I am trying to have that language of acceptance or inclusivity. Looking at your forms, your discussion points, your questions. And so this could be thinking about how, one really common example is thinking about just how we ask questions. And so, when we're working with someone, saying like, are you married? Do you have a boyfriend? Do you have a girlfriend? Like that sort of thing that normally is just kind of casual. Not everyone always considers the implications to that. And so thinking about the way we phrase questions, really trying to use gender neutral terms, looking at our forms and saying, are the checkboxes inclusive? There's only 2 options here. Wait, that's not, fully inclusive. Hawaii is great. I think it's July 1st on driver's license, right? A person can choose to have X instead of male or female. It allows to say, okay, there's this whole other group that exists and that we have been kind of covering up or silencing simply just from a form, a checkbox. So sometimes these things can be pretty simple in the context of like, did I just check my form? Was I thoughtful about this? Did I check the way I put my own presentation title? And trying to kind of make that ongoing effort. One example that I use specifically at the VA is military culture really values kind of having formalities, kind of having titles. And so it's really important that veterans feel that respect, but what could be a way that I'm inclusive with that? And so instead of using Mr., Mrs., I can use the title veteran. That's become more widespread, and so veterans understand that that's a way of just simply addressing them in an inclusive way. So that way, and this is the way I explain it to some veterans, because they might ask, like, what does that even mean? Well, just in case, I want to make sure that the language I always use shows that I want to serve all veterans. A really common phrase, especially with LGBT care coordination, is we're here to serve all who served, everybody. And so I want my language to reflect that. So thinking about that kind of language for yourself. And I think kind of the overarching goals that I would encourage everyone to have is trying to always think about providing information about services that are available. So that means that you might be working with an individual trying to work on housing stability, and you simply make sure you ask, are you a veteran? If so, okay, I want you to get connected to the VA, or I want you to get connected to this VA program. Another goal that I really encourage people to think about is our own personal advocacy and support for safe, equitable housing resources and policies that really address women's needs, that really address transgender veterans' needs. And so this can be done by broader policies. It could also be done by kind of the old adage of like the squeaky wheel, gets the oil or whatever that might be. I can't remember it right now exactly. But the idea that we all have a voice, and it might be that we're just kind of saying, hey, what about this? Hey, what about this? And if enough people start to really be thoughtful and consistent, then we're able to do this. And then assisting with care coordination. This one's pretty tricky because there's so many different agencies. And so for this, what I like to do is to encourage kind of role modeling. Okay, I'm going to write down the different things that are needed. I'm going to create kind of a list. And this is how we're going to go through it. I'm going to check back in. I'm going to do what I can. Ensuring that people have that accountability for themselves, and also allowing for them to have some support from ourselves. Okay, like let me go down the list. So those are kind of the overarching goals. Some really good VA programs that can assist with housing right here are listed. And so these are kind of formal programs. The top are aimed at kind of broadly veterans. The next in the middle with the women veterans, targeting for women. And then every VA has LGBT care coordination. So that includes kind of advocacy and support specifically for veterans that might have kind of those specific needs. So those are some resources that might be helpful. And so we have a few minutes left. And let's see. Okay, so I see one question. It says, why is it that women veterans are 4 times more likely to be homeless? Why is this? And I think that's a great question. And so that's going to be going back to kind of that earlier conversation, and I might just actually scroll up there to those social determinants of health. So what a lot of research has suggested is that because women have a lot more demands, more exposure to trauma, likely have increased mental health conditions because of that increased exposure, and less access, right? So as an example, what can happen is when someone transitions out of the military, part of their kind of transition is letting them know the resources that are available. Well, again, kind of going back to provider knowledge, if the individuals that provide that information don't give information that attends to a woman's veteran's needs, it increases their risk. And then we add on that women are often kind of tasked with caregiving at much higher rates. Then we add in the idea that we have kind of social demands of kind of putting their needs behind the needs of others. So we add these kind of different elements and then think about military culture, which often silences women, doesn't really attend to their specific needs. We're seeing that there's a lot of these social determinants that are increasing the likelihood that they don't have the resources that they need, that they're at greater risk for health conditions that predispose them for that kind of housing instability, and that we don't have housing like resources and support systems that attend to women's needs specifically. So it's a pretty complex process, and I think that your question just hits the nail right on the head of what we should be thinking about. Like, why is that? What is going on with that? And so part of that is thinking about that for veterans in particular, they're having those increased risk factors, those experiences in the military, both like it might be right the trauma factors, but it could be military culture. I've got to hold this in. I'm not supposed to ask for help. I'm supposed to push through. And so all of those kind of overlay and become a pretty significant issue that creates that kind of housing disparity. The one article that I would suggest, if you wanted to just read more, right here, yeah, is this 2003 article or this 2014 article. And like I mentioned before, the full references are in the notes section of this PowerPoint, so you can see that full citation.
Mary, I have some other questions that have come in.
Okay.
We'll try to kind of get to them all. I'll start from the first one that we received. So an attendee is asking, how is the VA currently handling the medical needs of transgender veterans? Are they actually covering the needs and costs of transgender veterans? I think this is in regards to hormone therapy, et cetera.
Great question. So yes, we actually do cover, the VA does cover transgender-specific medical needs with the exception of gender affirmation surgeries. So what that means is we provide specific kind of primary care services, hormone therapy. We provide an extensive range of prosthetics. We provide pre-surgery needs, post-surgery needs. We provide things like hair removal, voice coaching. We provide things like at the VA Pacific Islands, we have a notary on site to help with completion of documents, so if there's any kind of administrative needs. But the one that we're still working for, still fighting for, is as it relates to the gender affirmation surgery. So a typical process might look like a veteran comes in, they would get the evaluation that's in alignment with the WPATH, which is like the World Professional Association for Transgender Health. It is not, I always emphasize this to people, it is not a barrier where someone has to prove that they need this surgery. What it simply is it's a documentation that this is a medical necessity. So it's similar to if someone's getting like a kidney transplant. They go to see a provider to get an evaluation simply so that it shows, yes, they understand, they're informed, and now they can go to their medical provider and not have to have that kind of conversation. It's a great question.
Thank you. Okay, the next one, another attendee would like it if you could briefly describe some of the VA resources you listed. So I think towards the end there was a resource slide. If you could just, I think, briefly describe what each of those resources is.
Let me get there. So the first one's going to be like a nonprofit type of agency that basically tries to ensure that housing vouchers are specifically for families. The link to each of the descriptions of these and like the detailed information is in this PowerPoint, just so you know. So that's more of a family-focused voucher program. The next one is really the one that I think has the most influence, especially here in Hawaii. It's known kind of as HUD-VASH. So it's kind of a connection between the VA and Housing and Urban Development. And what this is this basically tries to set up veterans so that they're able to access different resources and they have ongoing support. So this oftentimes will have a social worker that's meeting with them on a regular basis, ensuring that they're getting their needs met. Do they have enough to pay rent? Is there any concerns about that? Filling out applications. It's very in-depth, and so that's a really great one. The grant and per diem program, this is going to be related often to like the travel and transportation needs in addition to housing. And so veterans are often eligible to be reimbursed for traveling to get their healthcare needs met. And so that's a program that helps offset the costs of travel. The next to the women, veterans, healthcare, and the mental health, it's the idea that, not the idea, it's the programs that are specifically aimed for treating women. And so what that means is a woman veteran could come to the VA and say, I want someone that's specifically trained with expertise in mental health care for women veterans. And so it's just the programs that are designed so that they're designated providers. The Center for Women's Veterans is just an overall program that addresses women's needs, so that's going to kind of be more of a general resource. And then the LGBT Veteran Care Coordination is that every VA has a minimum of at least one care coordinator that serves as an administrative advocate to know of the resources that are available, to provide training to providers, and help resolve any kind of conflict that a veteran might experience.
Great. Thank you so much, Mary. I know there's a couple other questions, but we are right at our time. So out of respect for everybody's time, we're going to leave it there. Mary, do you have any contact information that people can reach you at if they have questions that didn't get answered today?
Yeah, absolutely. So probably the best contact would be sending me an email, which is simply, I didn't put it on the first slide, but I'm going to go back there so you can see how to spell my name, which is mary.harlinger@va.gov.
And I'm just typing it into the chat there for everybody to see. Okay.
Perfect.
Thank you so much, Mary. This was a fantastic presentation, and we really appreciate you being here.
Absolutely. Glad to support. Let me know if anybody has questions.
Great.